So the screen's being shared, so whatever is there, you're ready to go.
Thank you.
And this is with...
Good afternoon. We're going to get started. We have a really full agenda today, a really exciting lunchtime seminar. I will say unequivocally, this is my favorite lunchtime seminar of the year. I love hearing about the interns' experiences, and we have never had 9 interns in 1 year. This is just incredible, and it's going to be a lot of great experiences. So we thank you for joining us, and for those of you who are attending remotely, we appreciate you joining us. And if you have questions during the event, you can type those into the little text box and they will be conveyed. We'll probably hold questions to the end, though, so we can make sure that everybody has a chance to get through their presentations. For those of you who don't know us, we are a CDC-funded injury control research center, and we're also supported by the University of Michigan. We provide training and educational opportunities, such as internships and fellowships, and we also sponsor pilot studies and research projects. We support practitioners and policymakers, and most importantly, we've just submitted our application for renewed funding. That went in the mail on Monday, and so you see a lot of beleaguered faces around here. A few announcements for our next lunchtime seminar. That will be October 6th. That's a Thursday. It'll start at noon, and we'll be featuring Quinn Epstein-No. She will be sharing work that she's done in the field of alcohol misuse and associated dating aggression. And Quinn was a recipient of fellowship funding from the Injury Center. We'll also be hosting a distinguished faculty seminar featuring Lisa Marsh on Thursday, November 16th at 4 o'clock. Dr. Marsh is the director of the Dartmouth Center for Technology and Behavioral Health, and she's an expert in the area of technology-based therapeutic tools for addiction treatment. So there's information about these events on our website, and so we encourage you to go to our website often. Before we get started, I want to do a couple brief introductions of leadership from the Injury Center who are here. The leaders of our Training and Education Corps are Sara Stein and Lisa Buckley, and they are the ones who actually did all the matching for the internships that took place. And somehow we always say the magic happens, and the magic is really a pretty determined effort by Lisa and Sara to find a good match between people's needs and the interests of interns. I'd also like to introduce Ray Bingham, who is a leader of our unintentional injury research. Patrick Carter heads up our policy work group. And Steve Stack is a consultant to our group, and he's from Wayne State University. And his area of expertise is suicide. So as I say, we're going to have 9 interns present today, so hold on to your hats. It's going to be a little wild and wacky. 3 of our interns went to Atlanta for the summer and spent time at the CDC. So they physically relocated to the South, which I'm sure was a culture shock in many ways, and we hope to hear maybe a little bit about that. So they'll tell us a little bit about where they are in their career, their interests, and the work they did this summer. And before we begin, I do want to thank all of the supervisors and mentors, the people that worked closely with these interns to make sure they had an enriched educational experience and a good training opportunity. We greatly, greatly appreciate you providing that experience and hopefully developing an ongoing relationship with a future worker in the injury field. So we will begin our presentations. And so we're going to hear first from Chris Bush, who was one of our CDC interns.
Do you want me to use this, or?
Yes, I would recommend.
Okay.
Just click that on and you can leave that sitting there.
Okay, great.
If you can't hear, please let us know early in the presentation. We'd like to correct it so they get a more valuable experience for all. All right.
Can everyone hear me okay? Okay, great. So yeah, my name's Chris Bush. I'm a second-year Master's in Public Health in the Epidemiology Methods and Applications program. As Tina said, I was one of the interns that was at CDC in Atlanta, and I'm actually from East Tennessee. So was nice adjustment actually to be back still. Yeah, some things I had forgotten about, but it was a really awesome summer, and I felt very privileged to be there. So I titled my presentation Opioid Use Patterns and Outcomes in Maine's Medicare Population. So this was the biggest project that I focused on while I was there. So I'll talk to you a little bit about that and pepper in some things that I learned. So I was within the CDC and the National Center for Injury Prevention and Control within the Division of Unintentional Injury Prevention, and I was on the Prescription Drug Overdose and Health Systems team. So that was one of the things I learned, was just the hierarchy of the federal government. So that was kind of where I cascaded down to. So in talking to my supervisor, Dr. Quinn Zhang, and the team that I was working with, we were kind of tossing around different ideas, and we decided to focus on using Maine's all-payer claims data. So we had pharmacy eligibility files, medical claims, and medical eligibility. And we had this from 2012 into 2013. It was quarterly longitudinal data. So we had basically almost every prescription record that was filed to an insurance company, both private and public, in the state of Maine. So these data sets were just massive, which was one of the first times that I ever been exposed to anything like that. But we stratified by age. So within the Medicare population, or getting Medicare, it's an entitlement program, but there's a few other ways that you can get it. So we stratified on age. So the elderly population were those patients who were at least 65, and then the disabled was anyone underneath it. And so the objectives for my project were to just describe and better understand the opioid overdose risk factors, and we looked at a lot. I mean, with those data sets, especially the medical claims and the pharmacy claims, we were working with sometimes hundreds of different variables. So the perspectives and the way that you can look at different things was pretty nice. But so we wanted to describe and better understand those risk factors in the elderly and the disabled, so trying to compare the two populations against each other within Maine. And then, of course, we can sort of direct these findings and the outcomes to help inform planning and direct where kind of policy or money should be allocated. And then just personally for me, through this internship, I wanted to develop more programming and analytic skills, and I definitely had that. So we looked at, as I've referenced, a lot of different outcomes, and I just wanted to highlight a few of them. So you can see, hopefully it's clear. The yellow is the disabled population, so those under 65, and then the blue are the elderly. And for each one of these outcomes, you can see the disabled population was much higher. So we had daily mean morphine milligram equivalents, which we know is a risk factor for overdose. The higher you go, the percent of patients with at least 90 days supply, and then the percent of patients with at least 3 prescriptions. And I really want to point out this graph. So as I said, we had quarterly data. So this represents that each of patients prescribed within those populations, they had every day within that quarter covered by an opioid, which was pretty interesting and pretty surprising. So the most interesting parts, looking at it from the operation level, so previously I had interned at a local health department before I came up to Michigan for school, and so that was kind of from a bottom-up perspective, and now I had it from the federal all the way down, which was really interesting. And then the scope of the work, this is the first time I had analyzed longitudinal data sets, and working with these, the size of the data was just massive. And also it was my first exposure to any kind of claims data. And then just the team that I was working with were so amazing. They were all so passionate about the work that they were doing. They were so professional and so inviting. I never felt like an outcast or that I was an intern or anything like that. They really incorporated me into the team, which was really awesome. And then just things that I learned. So more information regarding opioid overdose risk factors, and then how populations are affected differently. So in my classes and in the program and what we read in the literature, we do know that certain populations are affected disproportionately than others, but seeing that on this kind of first time and making these discoveries was really impactful personally. And then the interconnectivity of the government. It's kind of by itself, and we think of it as this almost strange place in terms of the federal government, and actually being inside of it and seeing how the operation is carried out was a really unique perspective, and how they interact between the sister agencies was also very nice in the collaboration that does take place. And then I also just learned more about myself and my career goals, which I'll mention now. So post-grad, after April, I would really like to work in a position that enables me to focus on health outcomes research, data analytics, health research, and then just applying and continuing to shape my programming skills. And the nice thing is I'm continuing my summer research and the relationships that I built there into this current year and working on some more projects. So that's exciting. And then I'd be remiss to not thank my supervisor, Dr. Quinn Zhang, our team lead, Jan Mosby, the division itself, Dr. Bonner, and then the School of Public Health and the Injury Center for funding me and giving me this opportunity. Thank you.
Thank you very much, Chris. Next up, we have Michael Jacobson. Thank you.
Hello, thank you for having me. I am Michael Jacobson. I am in my second year of the Health Management and Policy program here at SPH. And a little about me, I actually worked for the Centers for Disease Control for 2 years between my undergraduate degree and now. And last year when I was looking for an internship, I was looking for what part of the University of Michigan has a relationship with the CDC. And it seems like the Injury Center is the one that has the strongest relationship, so I'm happy for that. I'd like to thank the two for matching me with the wonderful Office of Policy and Partnerships. So where was I? In the Office of Policy and Partnerships in the National Center for Injury Prevention and Control. The Office of Policy, their responsibilities are everything on the political and legislative side of injury. So you'll hear about a lot of topics that the interns worked on. The opioid epidemic, concussions, sexual violence, etc. The Office of Policy and Partnerships is responsible for all those subjects in policy. So my internship consisted of working on a bunch of little projects in a lot of different areas. And my mentor was Sara Patterson. She was a wonderful mentor, and she leads the Office of Policy and Partnerships. My objective going in was to serve the Office of Policy. So my mentor was wonderful, and right away she was, trying to get me excited about, what do you want to work on? What do you want to work on? My strategy is, I'm here for you. Whatever you need to get done, I'll take that off your plate. So that's how I learned best, through a little osmosis, and that helped me get a little bit of everything. So a couple projects that I got to work on were, for example, evaluation is a core component of policy because we're trying to lead towards evidence-based policies and solutions. So one project was working on a evaluation policy presentation for states when they come together on rape prevention education, how to make sure that the rape prevention policies and education that we are implementing are strong and evidence-based. Another project that I worked on was the transition planning for a new administration. So it was kind of wonderful timing that it's an election year, and no matter which administration is voted in, the center has to be ready on the policy side to be able to illustrate and communicate what are our policy priorities. And so there was a lot of paperwork and forms in order to illustrate whoever's in charge, whether we get a new CDC director or not. This is the center's priorities and what we're going to be looking at for the next decades to come. And another project was to work with the center's leadership on helping to frame the strategy for the opiate epidemic. So it'd be like a lot of sitting down and making sure that the message is being communicated correctly to the public and to the states. When I was working at the CC, I got to meet a lot of the influential persons that helped strengthen me as a public health official, from the division leaders, my team, and even outside of injury, I was able to get that. One of the most important things that I took away from this internship is my gaining knowledge on the field of injury. I have a background working on infectious diseases and chronic disease, but this whole realm of injury, which is so important to public health, I was missing that, and being able to work on this wide variety of injury-related subjects really strengthens me as a public health official. Important, as Chris mentioned, learning the policy process. How is the federal level communicating with the state? So when working on an epidemic like the opioid overdose epidemic, how is the CDC communicating to its states? How are grants getting pushed out? And how are they received and implemented? One fun project that I really enjoyed, it was actually a week-long project. And how it all started was the director of the CDC, Dr. Thomas Frieden, he emailed our director of the center, Dr. Deb Bowery, and he goes, a certain section of the Affordable Care Act, I heard a certain state was using this. Can other states do it? And she forwarded that to my mentor, Sara Patterson, at the Office of Policy Partnerships, and then that was emailed to me, the intern. So can you look this up and give it back to the director? All right, I'll do that. So I got 6 pages of information about the Affordable Care Act policy, put it together, and presented it to my boss. Oh, this is great, Michael, good job. It can't be 6 pages, though. Can you scoot it down, though? Okay. So I go back, I shrink it down to 2 pages. Oh, great, Michael, this is good stuff. But it's got to be a little smaller than 2 pages. So it's like, oh, okay. So learning how to summarize a complex funding policy of the Affordable Care Act for other states into 2 paragraphs is a wonderful policy experience. I enjoyed my time at the CDC. I can see myself returning in the future, but for the next decade or so, I see myself working in Michigan. So I'll be looking at the state level or institution level like the University of Michigan. Thank you so much for this opportunity. Learned so much from everything. Can't thank you all enough. Thank you.
Thank you so much. Our next speaker will be Sanjana Pampati, and she was also at the CDC, and she's going to tell us about her experience there. Okay, as she said, my name is Sanjana. Is this working? Okay. So I worked on the Adverse Childhood Experience study, and I was at the Division of Violence Prevention at the CDC in Atlanta. My mentor was Dr. Melissa Merrick, and I worked with the ACE group, so that included several other people, but she was my main point of contact. And before I talk specifically on what I worked on, I wanted to talk about the topic in general to kind of give you a little background. So the issue is that over 1 billion children experience violence annually, and this statistic includes physical, emotional, and sexual violence. It doesn't include neglect. And a lot of our understanding of how violence affects us comes from a study on Romanian orphans. And on the right, you can see a picture of an injured brain of a Romanian orphan who was severely neglected. And then on the left, you can see a healthy brain. So basically, violence and stress early in life affects like the neural circuits, and the brain doesn't really develop as it should. So a lot of times when you think of child abuse and neglect, you likely picture stuff like broken bones or bruises, or maybe depression and PTSD. But you probably don't think about asthma or diabetes or heart conditions or decreased academic performance, which brings us to the Adverse Childhood Experience study. So there's 3 main categories of ACEs: abuse, neglect, and family challenges.
Abuse includes physical, emotional, and sexual, and neglect includes physical and emotional. And family challenges include mental illness, incarcerated relative, mother treated violently, substance abuse, and divorce. And of course, this really doesn't encompass the whole range of early adversity, but it kind of gives us a place to start. And 7 out of 10 of the leading causes of death in the United States have been linked to ACEs. So our group really wanted to see how ACEs affect adult health outcomes, which brings us to some of the things that I worked on. One of the things I started as soon as I got there was a case study of Alaska's ACE work. Alaska was one of 32 states who included the ACE module into their behavioral risk factor surveillance system. And compared to other states, they found that their ACE scores were relatively high, and a lot of that has to do with the fact that they have a pretty high native and tribal population, and the children within those populations are particularly vulnerable. So what this required was me talking to all sorts of stakeholders in Alaska. I talked to the Department of Juvenile Justice, the Department of Education, several pediatricians. I talked to the Department of Public Health, and basically I created a case study for other states so that they can know how to start doing ACE work, both as it comes to prevention and treatment. This is currently still in the works. It's going to CDC clearance eventually, so that's a long process, as I've learned. Another thing I worked on was a research review of immigration history and ACEs. One of my main research interests is immigrant and refugee health, and my mentor was interested in incorporating my interests with her interests. So I got to write this review, and basically one of the main findings was that the effect of immigration history has a unique contribution to early adversity that can't be explained by race and income. And the purpose of it, the takeaway, is that maybe we should expand our ACE module to include experiences that are more unique to immigrants and refugees. And this is also something that's still in the works. I worked on a paper on child sexual abuse. A lot of the research around child sexual abuse kind of just treats it as a dichotomous exposure. It either happened or it didn't, and this is the effect. So we were more trying to understand the specific characteristics and situations where child sexual abuse occurs. So the perpetrator, the age, how often, what type. So I used data from a large HMO, and after I just used a subset of people who said that they experienced child sexual abuse, so I had about 3,000 subjects. And I used R and SAS. I mostly use SAS. And some of the main findings are that the age of abuse is much lower for females compared to males, and that also males are more likely to be abused by a stranger, and females are more likely to be abused by a relative or someone that they trust. But in general, for both males and females, people knew their abuser beforehand. So here are a few other projects that I got to work on. I helped write a brief report for the American Journal of Public Health on the results of the 2012 National Intimate Partner and Sexual Violence Survey. I drafted an introduction to a paper on residential stability. I assisted with a systematic review, and I helped create a presentation that was presented at an Air Force training for violence prevention. And I also got to attend that training, which was really cool. So little takeaways from my internship was that in those 2 months, they were really productive. I've done more than I usually do in a year of being a research assistant. I knew beforehand that I probably wanted to do a PhD, but this really solidified my desire to do a PhD and eventually maybe work at the CDC, because I've only worked at academic institutions up until this point, so this was a very different experience, which I've learned a lot from. And the people in the ACE group were really supportive, and there are definitely some people that I'd like to work with in the future. I still have ongoing projects with them that I'm working on, so that's been really great. And I really wanted to thank the Injury Center for providing funding for this, because this has been just a really positive experience for me.
Thank you so much. Those are some great experiences in Atlanta, and we're going to switch gears now to the 6 interns who had internships here more locally, both with academic researchers here on campus or at Wayne State, or with community partners. And to lead us off, it will be Kate O'Connor, and she's going to tell us a little bit about who her mentor was and the work that she did. Not sure this thing's on. We'll try to do this. All right. Well, thank you, Tina. So as she mentioned, I did not go to Atlanta this summer, but I did relocate from Central Campus up to North Campus, which is a change in environment all in itself. So my name's Kate O'Connor. I'm a third-year PhD student in kinesiology, and I got kind of matched up with Dr. Eckner and Dr. Ashton Miller. Dr. Eckner is a PMR doc looking at concussion, and then Dr. Ashton Miller is working in mechanical engineering and looking at kind of the mechanics of injury. And so my research is on TBI and concussion, so I just kind of took a different perspective on it. And so concussion is kind of a big interest of the CDC and injury. There's about 600,000 mild traumatic brain injuries that present to EDs each year. And this is actually likely an underestimate of the actual injury burden, because these are only injuries that arise to the ED. It's not counting primary care visits or injuries that don't arise or need medical attention. Furthermore, mild traumatic brain injury actually has a greater population cost burden relative to compared to moderate or severe TBI, which may sound counterintuitive when you consider that a severe TBI requires a neuro ICU visit or extended care, but it's really driven by the prevalence of how many injuries occur. And these numbers posted here, it's about $700 million just for the 3 months after a mild traumatic brain injury. And so these are only the 3 months total cost for the injuries. Furthermore, concussions have been increasing in the past decade. There's been about a 16% increase in rate in concussion in the past 10 years. The caveat being, though, is that most of this is probably driven by increased awareness and increased reporting. So right now, we're probably hovering at what the kind of true incident rate is. And so when you look at concussion or mild traumatic brain injury, there's kind of these series of events that occur. And so the research I did over the summer was looking at different aspects in this kind of concussion timeline. So there's these pre-impact or predisposing factors. So what makes a person more or less susceptible to an injury? These include probably hydration status, genetics, and neck strength. Then when you have an impact that occurs, there's a different kind of biomechanical signature that may or may not create an injury. After force is either applied directly or indirectly to the head and then the brain, there's this kind of cascade at the cellular level that occurs, and it disrupts the function of the neurons. This disruption of the neurons then causes these symptoms like headache or dizziness that people commonly have. But the good thing is that about 90% of these patients will recover within 7 to 10 days. So what I worked on over the summer was at certain aspects. So looking at kind of pre-impact factors, so neck strength. So can neck strength or increased neck strength reduce the forces that are applied to the head, and thus reducing concussion risk? And then because I'm a PhD student, I'm mostly on the research side, I wanted to remain grounded in kind of the clinical care of these patients and what kind of clinical symptoms arise after an injury. So I shadowed Dr. Eckner in clinic and kind of viewed a few of his cases in there. So I'll kind of touch on mostly the neck strength work we did and then the clinical work we did. So in terms of prevention, as I mentioned before, we were looking at neck strength, and the hypothesis kind of guiding this project was that increased neck strength will reduce concussion risk. And up here, I've highlighted the 4 main muscles that we were interested in, and we chose these 4 muscles because these 4 muscles work in 4 planes of motion, either frontwards, backwards, laterally to the side, or rotation. So looking at those 4 planes of motion, how could we reduce the forces applied to the head? How we did that is we did kind of a multimodal way. This is not a torture device. This is what we came up to systematically apply forces to the head. What we did is we modified a wrestling headgear, and what we did is we instrumented it with kind of a wire with a weight, and we would drop that weight that was proportional to their body size, so their weight and height. These were forces that are substantially lower to what these athletes would sustain in their sport or their contact sport. But it was a systematic way for us to apply a force to their head. We then captured data using EMG sensors. So we looked at muscle activation. We used motion capture cameras to look at the kinematics of the head, how it responded to different tugs in different locations. And then we used non-helmeted accelerometers. So this picture here with the accelerometer behind the ear.
to look at the accelerations of the head as well. So we used all that data together to look at can neck strength be associated with reducing the forces applied to the head. And then a subsequent aim of this project was looking at what's the best measure of neck strength. Is it the EMG activation? Is it the muscle size? So using sonic ultrasound, can we look at the size of the muscle belly and look if that will kind of also be a good measure of neck strength. So then in terms of the kind of clinic work we did, so I shadowed Dr. Eckner in clinic. We saw a whole variety of patients, excuse me. So different ages, different mechanisms of injuries, acutely, chronically after their injury. And one thing we kind of saw is that there's kind of a few cases that are very unique that we don't consider in concussion, these kind of unique mechanisms of injury. So what we thought is we would come up with like a case series and we would describe these injuries. And the nice thing is that from all the data that these patients give us, we're able to almost reconstruct the injury. So working closely with Dr. Ashton Miller, I had to recall all my high school physics, which was painful, but we did it. And so what I have here is, this is a possible ball trajectory. So this was a high school female. She went up to jump and head the ball. She misheaded it, and the ball hit the top of her head, and it caused a concussion. So this isn't kind of a injury you would necessarily consider, you think big tackling or big impact would cause a concussion. So this was an interesting one for us. And so basically we modeled using different parameters, the possible trajectories of the ball, and then thus the possible forces applied to her head. And so the kind of skills and experience I gained were really in terms of data collection and data analysis for that head tug study and the neck strength study. It's a lot of different modalities that I haven't been exposed to before. And then in clinic, it just kind of reinforced being tied to the clinical presentation of these injuries and then the recovery trajectories of these patients. So I just want to thank the Michigan Injury Center for this experience, along with the CDC, the Neurosport Clinic for allowing me to visit, and then my advisors for this summer, Dr. Eckner and Dr. Ashton Miller. So thank you.
I think Dr. Eckner was joining us via webcast. Dr. Eckner, did you have anything you wanted to add? Possibly. All right. I'm sure he was going to say, she was fantastic. Oh, okay. So he submitted in writing. He did a great job. We knew that. All right. Next, I'd like to introduce Miriam Gleckman. Is it Krut? All right. Thank you, Miriam. Is this working? Can you hear me? Okay. Oh, it is? Regardless, I can project. My name is Miriam Gleckman-Krut. I'm a sociology PhD student here at the University of Michigan. I research sexual misconduct prevention education, and the Injury Center gave me an amazing opportunity this summer to work under Dr. Eric Bonar in psychology, which is a subject not my own, and so that was really exciting. So to give you a brief, again, outline of the issue, I'm going to start by talking about national prevalence, and then I'll put some of this in the context of the University of Michigan, as the research project we were involved with really was looking at the university. So the Obama administration famously publicized the statistic that 1 in 5 women are assaulted during their time in college. That same study also found that 6.1% of men and 21% of transgender or genderqueer or gender nonconforming persons are also victims to this crime. So this is an important impetus behind the research, which is to promote equal access to education on the basis of gender at our institutions of higher education. The statistics at the University of Michigan are fairly comparable. So that's 22.5% of female undergraduates and 6.8% of male undergraduates. So again, relatively reflective of the national averages or the national rates. And these statistics indicate that most cases occurred under the presence of alcohol and/or verbal pressure, and that most perpetrators knew their assailants. We heard research similar to this in the past. That's an emerging trend, is that sexual violence generally seems to be occurring between people who knew one another. So this issue is actually relatively new to the field of injury studies, and I want to give you a little bit of a sense of how it fits into this larger context of injury. So first of all, the CDC says that victims of sexual violence often experience chronic pain, gastrointestinal disorders, gynecological complications, anything from STIs and cervical cancer. In addition, 33% of rape victims contemplate suicide, which indicates some of the psychological effects of sexual violence. It incites some depression. And similarly, another reflective trend in another trend that reflects the psychological effects of sexual violence, people who are assaulted are more likely to use drugs compared to the general public. So I firmly believe that the best form of intervention is, in fact, prevention. And the University of Michigan is really leading the way in terms of how to prevent violence happening on this campus. One of the ways that they're doing that is through mandatory programs for first-year students, which is what I will get into later. Relationship Remix and Change It Up are the big ones there. But they also have population-specific programming. So that's talking to athletes, for example, about how to deal with sexual violence happening amongst their populations or populations related to athletes. So while I was working here at the Injury Center in NCRC, I worked on a number of projects. MClass, Sexual Violence Perpetration Pilot, was a survey data collection, and Raise the Bar project evaluation. So each of these, the common denominator is some form of prevention education or prevention research. I'm going to be speaking with you specifically about my experience working on MClass, which was an interview-based project, evaluating Relationship Remix and Change It Up, which is what I mentioned previously. So the goal of MClass was to interview students at U of M who had gone through these trainings about their experience with the training and their experience at the university with the prevalence rates of sexual violence. You know, those statistics tell us one thing, but personal experience really speaks for itself in some cases. And so we wanted to get at that personal experience with the intention of designing a really a different and better tool, honing our tool, adapting, developing. So the project design, we had focus groups and interviews with so far 25 rising sophomores. We're still in the process of data collection. And these interviews were sampled in proportion to the University of Michigan population. So we actually, for those 25 interviews, had almost 250 people asked to join our project. And we had, therefore, an amazing opportunity to say that we really want to talk to this number of women, this number of men, this number of gender nonconforming people as proportionate and very intentionally to the population of the University of Michigan. And we intentionally did not speak to students who were involved with relevant organizations such as SAPAC, which is the Sexual Assault Prevention and Awareness Center here at U of M, because we wanted to talk to the general population. This was my first opportunity to recruit participants and then to select a sample. And as somebody who's going through a PhD program, that's invaluable because I'm going to have to be doing that a lot. So I'm going to give you a few tasters of the types of things that start coming out in interviews. This quote, I was talking to the participant about partying at the University of Michigan, and she explained that that drinking to her is like an after-school sport. In that it structures the time, the way that she uses her days, and that it's very physically demanding, and so therefore she has to change parts of her life in order to keep this incorporated. Now, if you're designing a prevention tool and you tell somebody like that, just stop, they won't. And this is an important, these types of interventions, this type of qualitative data will be really important for informing how we're going to be designing new programs, and perhaps harm reduction techniques can come into play. Another quote that stuck out to me in my memory to Dr. Bonar and myself, my supervisor, is this one about a young man describing his experience of picking up women at fraternities, in which he described the process as similar to going fishing, in that it's relatively easy and it's the type of thing to be expected once you are there. Again, something that can inform prevention education efforts.
Finally, these are a few early suggestions that we've come up for designing new intervention efforts, including considering harm reduction techniques. The prevention programs, a lot of students said that it should be offered more frequently and later in the semester. And there also was a large push for survivor testimonies and wanting to hear about what the experience really is like of all those general trends. So this project is, again, as I mentioned, still in the process, still in the works. So I have the wonderful opportunity of continuing to work under Dr. Bonar this semester to do an independent study, which is an opportunity entirely facilitated by this internship and made possible by this internship. So I really appreciate it in that respect. And we hope to continue coding those interviews and coming up with some publications from them. In addition, we hope to offer the University of Michigan a strong suggestion about how they might improve and add to their prevention education programs. This was the thing. I really owe many thanks to a lot of people in this room, particularly Dr. Bonar, who's here. This was definitely one of the most impressive internship programs I've ever been a part of, and I've had the honor of being part of a few, and that I felt very listened to and respected, and I learned a ton. And it also facilitated my opportunity to continue working in something that I feel very passionate about. So thank you.
Thank you, Miriam. Dr. Bonar, do you have anything to add? Well, thank you. Thank you for giving her the opportunity and mentoring. Next, we'd like to welcome Grace Phenisee.
Hi, I'm Grace Phenisee. I'm a second-year HDHE student in the School of Public Health. During the summer, I worked in the Prevention Research Center of Michigan. They promote a safe and healthy future through prevention research. They do a lot of research, including sexual health, drug and alcohol use, and physical activities, and many more. During the summer, I was involved in 2 different projects with the school safety in elementary school and school safety in high school transition project. Both of the projects we work with the Flint Community School. So unfortunately, because of the Flint water crisis, the elementary school project, it got pushed back, so it will happen next year. But for the high school transitioning project, we will going to do pilot study pretty soon. And I also had opportunity with doing my own research using Flint adolescent study data, looking at the peer relationship and their behavior among their adolescents. So as I talked about it, school safety and high school transitioning, we will do a focus group or the pilot study with 7th and 8th grade students in Flint, Michigan. And we will look for the school and community violence and how they affect as they make a high school transition to high school. For my research project, I looked at the peer support and relationship between the peer support and the peer delinquent behavior using FAS data. So I divided with the 4 different groups with the high peer support, low peer support, and then high delinquent behavior and low delinquent behavior group. And then I grouped them with the median using a median split. This is the result and then the outcome variable that I looked at. Outcomes, we looked internalizing variable and externalizing variable. As you can see, the group membership is related to the outcome variable except depression and self-acceptance. I'm still working with the result section and see the relationship between and then possibly the causal of the relationship. The most interesting part for me was definitely data analysis and data cleansing. This is my first time using such a big data, and first time of actually using the SPSS for data analysis. So it was a really good learning part for me. So definitely a research process that I learned from forming a research question to report a result, and I'm pushing, or we're trying to write a paper for publication by end of this year, and I'm doing it as an independent study right now, and also I'm still involved in continue to evolve in the two projects that will happen pretty soon. I'm really want to thank for Injury Center and also PRC for having such a wonderful opportunity and also for the support. Thank you.
I saw Dr. Phenisee here earlier. Did he have to leave? He did, okay. So we'll just assume that he was going to say wonderful things. Next, we are happy to welcome Breanne Helmers. Breanne is actually a student at Wayne State, and her internship was at Wayne State. So we are not completely U of M focused. We do spread out, and we're eager to hear about your experience.
So as Tina said, my name is Breanne Helmers. I'm a second-year PhD student working with Dr. Antonia Abbey at Wayne State. So luckily, she was able to take me on there, and I didn't have to figure out Ann Arbor. I feel like most of my internship, it seemed, was trying to figure out how to get around here, but I did do a lot of work, I promise. So I focused my summer studying sexual aggression and heavy drinking academically. So hopefully that's not confusing. So as I said, I worked with Dr. Tony Abbey and her current graduate students and a former student at Wayne State. I had three main objectives to work on over the summer. The first was to focus on developing a survey examining different risk factors of perpetrating sexual aggression in intimate relationships. She's done a lot of research in this area, and she's found out that there's not that much information on perpetration in long-term committed relationships, so that was more of our focus. I also analyzed data investigating the influence of peer pressure on heavy episodic drinking in adult men, not just adolescents. We wanted to see if there's still a relationship there into adulthood. And then I also collaborated with her current students on a manuscript that they already had in preparation, and they needed help forming the discussion. And I have a background in alcohol studies, so that's where I got to help out. So I researched and compiled a bunch of different survey measures, trying to predict sexual aggression in long-term relationships. Most of the measures that I'm focusing on deal with adherence to like heteronormative scripts, conservative gender beliefs, things like that. Those are what I think are going to be more likely to predict sexual assault in long-term relationships. And I'm still going to include information about casual sexual encounter perpetration, but that's not the main focus of this survey. I also analyzed the data investigating the influence of peer pressure on heavy drinking in young adult men, and I found that greater pressure from friends and greater past year alcohol use interacted to predict more heavy drinking episodes in the men in the sample. And then, as I said, I contributed to the discussion section of a manuscript investigating the influence of alcohol on men's sexual aggression toward a simulated date. This is a study that she had already completed before I started working with her, where she brought men into a laboratory, randomly assigned them to consume alcohol or not, and then set them in front of kind of what seems like a game of Sims, but a little more realistic, where they get to interact with a female date or female partner on a virtual date. And we recorded what they said to her, what actions they took with her, and we went in and coded all the data and tried to figure out how men reacted. So what we found was that men who consumed alcohol were more aggressive with her, tried to engage in more sexual acts with her even when she refused the sexual acts, and said more hostile verbal comments to her. So it was very interesting to work on that project. The most interesting parts of my experience with this was learning about a new type of data analysis. One of her former students that I was collaborating with taught me about latent profile analysis, which I'm just learning a little bit about, so I can't give you too many details, but basically you can take different pieces of information and create groupings of different types of people and predict behaviors that they might engage in. So we're using that in the heavy drinking study information that we have. I also got to spend a lot more time focusing on the current research related to sexual aggression, perpetration. This wasn't my primary area of focus before I came here, but I'm really interested in getting into this because understanding the types of factors that contribute to perpetration can really help us when we're creating interventions to reduce this. I learned that dating simulations can be used to measure sexual aggression. This is one of the first studies doing that. There are a lot of different sexual aggression proxies out there, but this one kind of seems a lot more realistic because the person's actually engaging in behaviors that they would actually engage in on a date instead of just saying when they think sexual aggression happened during a date that somebody else is in. I also found out that peer pressure still influences heavy drinking in adults. So we need to figure out how to consider those factors when trying to reduce heavy episodic drinking. And that sexual aggression is underinvestigated in the realm of long-term committed relationships. So I see that this is really where my research focus is going. And I really want to keep pursuing this, especially in different subgroups like LGBT relationships as well. So at the end of this, I have been able to apply to 2 different conferences and get posters submitted or accepted to them. So one's on the Wayne State campus for the robust program that they have, and then one's for a big social and personality conference that'll be in San Antonio. So I'm excited to go to both of those. I'm going to keep analyzing the heavy drinking data, and we're starting to work on a manuscript that we can hopefully submit somewhere by the end of next semester. And I want to submit the survey to the IRB and collect data on that. Hopefully use that to determine what I want to do for my dissertation. And then I'll keep working with Dr. Abby and her current and former students as well. So thank you all very much.
Breanne just reminded me that for all of the interns, we're happy to participate in this part of your career, but we are also interested in what happens as your career progresses. And so please do keep in touch with us. Let us know how your career is developing and how we can support you, even if it's just go get them or if there's something more that we can do. Because we do an internship program because we want to help train future workers in the area of injury prevention. So please keep us posted on how we can support you. Next, we're going to welcome Sara Stein.
Good afternoon, everyone. My name is Sara Stein, and I am a third year student in the Clinical Psychology and Social Work Joint Program here at the University of Michigan. This summer, I worked with Dr. Quinn Epstein-No on her project, the Mind and Voice Project, and my presentation is entitled Preventing Problems with Substance Use and Interpersonal Conflict, a Remote Mindfulness-Based Intervention. Can everyone hear me? Yeah, okay. Great. So this intervention that's currently in the stages of being developed and implemented for evaluation is an 8-week remote indicated intervention for substance use and interpersonal conflicts. That includes intimate partner violence perpetration, but is not limited to intimate partner violence. This intervention uses a contemplative motivational interviewing and cognitive behavioral therapy framework. And as I said, it's remotely done. So it's going to be done over a platform like Skype with weekly boosters via text message, so weekly between session communication with the therapist via text messages. So this is kind of a silly picture of a dog meditating, which borderline inappropriate perhaps, but it really speaks to a lot of what I did this summer. I was looking for an image, a mindfulness image that was creating the presentation that wasn't based in a like an upper middle class white population doing mindfulness, doing meditation, doing yoga. And that was a very hard image to find. So a lot of our work this summer was looking at qualitative interviews, about 75 that were done in the ED department in Flint, Michigan, with the population that is going to be receiving, or this intervention is being developed for. So low income, high risk populations for both substance use and interpersonal conflict. And so we combed through these 75 interviews, which are about 30 minutes each, having extensive qualitative coding meetings and discussions, looking at the themes, looking at what does mindfulness look like in these community contemplative practice? Are these things that are well responded to? Are these things that are needed? And so that was much of the activities this summer. I worked heavily on looking at the therapist training manual, which is currently in the stages of development, or now finished, but it was something that looking at the program and what elements need to be integrated into the program. We are also, now I'm participating in the intervention implementation stage. So this included during the summer participating in training, clinical training. I'm a clinical social worker, and I will be participating in delivering the intervention. So being trained throughout the summer on the intervention, especially the use of technology and how text messaging is going to be implemented through the intervention. And we are hopefully going to have our first participant within the next couple of weeks, so that's very exciting. I'm also now in the stages of training new clinicians. So that's one of the projects that I now am taking on, which is an important part of the intervention implementation. And of course, data analysis. So in addition to the qualitative coding that we are doing, we are now using that data to identify themes and to work on manuscript development and publication. We also have a data set of about 900 participants who went through a quantitative screen that we did. And current work is being done on data analysis there. So we are, as I said, kind of in the preliminary stages of data analysis, but there's some really interesting preliminary themes that we've seen in the work that we've been doing, so I thought it would be really interesting to talk about that. So one of the things that we were seeing in these interviews was that the men and women that we were interviewing talked a lot about affect regulation difficulties. So difficulties down-regulating when they got upset. They got upset in interpersonal conflicts, be it with a partner, with a family member, with somebody in the community. So someone said, for example, stress is my biggest problem. My feelings about a lot of things. I get really angry, I'm in a lot of pain, a lot of physical pain. I have feelings go up and down, and I just want to explode. I don't know what to do. So in that context, many of the participants talked about substance use and IPV perpetration. Substance use, somewhat surprisingly, was not just something that people were going out to do as fun, or at least reported as something that people were going out to do as fun, but really something that was used as a down-regulation tool. So this is either before IPV perpetration or after IPV perpetration, but a way to get themselves to calm down. And a lot of the participants reported needing other tools. So knowing that they needed other tools, but not having other tools besides substance at the moment, and that has been the only thing that they found to be effective. We also looked at the role of social media in increased interpersonal conflicts. And we saw not so much that violence was happening over social media, but that social media was really increasing interpersonal conflicts, especially within partnerships. Then we noticed a lot of differences in terms of how people were defining what intimate partner violence was, for example, based on whether they were a man or a woman. And I don't have a huge amount of time to go into details of all these things, but I just wanted to make sure I mentioned them. And then we also looked very heavily into the participants' responses to a body scan that they did in the ED. And there was an overwhelming positive response to having participated in this activity. So future directions, we always think that over the summer we'll get 5 manuscripts written, and that tends to not always be the case, even if you're working really hard. So we're currently in the manuscript development process. There are 3 or 4 papers in the works. And as I said, we are just about to start the pilot intervention program. So hopefully I will have my first participant within the next couple of weeks. And then once this pilot is complete, then hopefully I will participate with Dr. Epstein-No on some of the program evaluation. I would like to thank the Injury Center and of course the CDC for their support of me over this summer. Dr. Quinn Epstein-No, who it was a very surreptitious matching, I would say. We both went to Wellesley and have very similar interests, and so it's been a very great partnership, and I look very much forward to continuing to work with her. One of her RAs, Jessica Ramirez, and I did many hours of qualitative coding together, and I've learned a lot from her. The whole Mind and Voice project team, and of course the Injury Center staff, including Tina, who exchanged millions of emails with me, and I really thank you for all your support. So I have a question slide, but I believe at the end we'll answer questions. Yeah, thank you very much.
All right, our last presenter for the day, and I hope you've been making notes for questions at the end because we will have an opportunity. We have Sammy Madson. She's going to talk about her internship here in Washington County.
Thank you. All right, can everybody hear me all right? Great. So as she said, my name is Sammy Madson, and my internship focused on the opioid epidemic, specifically here in Washtenaw County. So I was lucky enough to actually be placed at 3 different sites instead of just one. I spent time with the Community Mental Health Partnership of Southeast Michigan, the Center for Healthcare Research and Transformation, as well as the Washtenaw County Public Health Department. All 3 of these organizations are active members of the Washtenaw Health Initiative, specifically in their opioid project. And a lot of my activities sort of revolved around the WHI opioid project. So my objectives for the summer, as I said, I was with 3 different organizations. During my first 2 months, I worked with Marcy Scalera at the Community Mental Health Partnership. She is the Director of Clinical and Substance Use Disorder Services there. I also worked with Teresa Dreyer at CHART, who was a policy analyst. She's moved on from that organization. And during my time there, my objectives were really to assist in sort of the day-to-day workings of the opioid project, and also a large portion of my time was spent developing a consumer-facing website for the opioid project, specifically focusing on Washtenaw County. My 3rd and final month of the internship was spent with the Public Health Department here, and Adrienne Waller, who is an epidemiologist with the Health Department. And she needed some health communication materials made also addressing the opioid epidemic here in Washtenaw. So I worked on a number of projects, but I'm just going to have time to highlight 2 of them here. So the first thing that I did, as I said, was create a consumer-facing website. This is sort of the top half of the homepage. Our primary target audiences were people struggling with substance use disorder, their friends and family, as well as practitioners who want to learn a little bit more about the epidemic. There are about 10 main content subpages on the website addressing various needs of those audiences. All of the text on the website follows best practices for health communication materials. So lots of links for easy navigation and resources. Everything is written at an 8th to 10th grade reading level, best practices like that. You might notice that this doesn't necessarily look like your average health website. We wanted to make the visual style sort of friendly and non-threatening to encourage engagement with the material. And I also made sure to include some graphic design best practices, hopefully to promote sustainability of the website, as well as promoting a consistent visual brand as they make edits and sort of evolve this project over the years. The other main project that I worked on was an infographic for the Washtenaw County Health Department. My preceptor there, Adrienne Waller, has been creating a really wonderful report on the opioid epidemic. She produces it about quarterly, and it tracks different trends. She wanted a more visual representation of some of that data. So she and I worked together to sort of identify different stories that she wanted to tell, and her primary concerns were the changing demographics of who is experiencing opioid overdoses and also who is experiencing a fatal overdose. The main thing that we noticed there was that the age is going down, and it's actually going down very significantly for women. It's dropped by 15 years in the last 6-year period. And she also wanted to highlight the dangerous upswing in fentanyl overdoses. At this point, I believe over half of all overdose deaths in Washtenaw County are fentanyl related. Certainly the most interesting part of my internship was gaining insight into substance use disorder and the opioid epidemic. Most of my experience in the past has been focused on sexual and reproductive health, so this was a really enlightening summer for me. Also, my background is in the fine arts, and it was really wonderful to see opportunities to integrate skills that I didn't imagine would be useful in public health. What I learned, none of my courses have actually discussed substance use disorder or the opioid epidemic, and I was a little bit shocked to see the severity of the problem. And I'm really glad that I had the opportunity to learn so much. I think it's going to be useful as I progress in my career. I also learned the importance of engaging stakeholders outside of the world of public health. The opioid project has had a lot of successes, and that's primarily due to bringing in community partners. I also learned how important it is to be flexible and roll with the punches, and that things sometimes just don't go the way that you're going to expect, but that doesn't make it any less valuable. Future plans, I know that the opioid project is planning a media push coming soon, and they're increasing their efforts to reach out to the community with resources and information. My personal future plans, I am eagerly awaiting graduation in April of 2017, and I am looking forward to moving back to Grand Rapids, Michigan, hopefully pursuing a career in public health practice. Thank you so much to my three preceptors, Marcy, Teresa, and Adrian, as well as the staff at each of the organizations. They really made me feel welcome. I don't think she's listening, but special thanks to Carrie Reingans, who was absolutely vital in getting our website up and running. Thanks to the Injury Center for facilitating this experience, and there's my information in case anybody wants to email me. Thank you.
That was a lot to absorb, wasn't it? It's a lot of good presentations. I neglected after Sara spoke to ask Dr. Epstein-Noe if she had anything to add about Sara's internship. Did you want to say anything?
I just say that Sara was phenomenal this summer and just did amazing work on the interaction development piece. It's not easy. It's not an easy task to incorporate so much information from the interviews that we had to make sure that the intervention was informed and appropriate to the population. It was a lot of work.
Thank you. We have an opportunity for questions for any of our interns or questions in general. Anybody have any questions?
A few presented on sexual assault prevention. I just kept thinking, has anyone considered partnering with those developing the companion app? Do you know what companion is? So students at University of Michigan Business School are developing an app, and it might be launched, which allows a person in a situation where they feel threatened to put either an alert, they put a series of friends in, like in emails, and they can put an alert at different status levels. So they can alert, I don't feel comfortable right now, or they can alert 911 and different things, and it shows the companion where they are around the community. So it's definitely around college towns, so you're going out of the bar, the companions know that you're out, and they can see each other visually on the map. So it's a lot like any of the visual mapping. So if you could get data from the back of your companion, I kept thinking, wow, you could use it in this research to track, where are people feeling threatened, and then what's the next step, and are they in those frat houses or the bars or whatever. So this is at the U of M Business School. In fact, there was an alert for UMHS health system about the fact that they were developing a company while they were in business school, and that just came out recently on knowing their email system.
So the question for those on the webcast is if the folks involved with the sexual assault have had any interaction with the people developing an app in the business school called Companion. So Miriam and Breanne, I guess those would be. What other questions? We can't let them off this easily. Andy.
Sounds like you guys had an amazing experience. Wondering for next year's cohort, you kind of look back or, look back on your experience and give advice for next year. What are some things that you learned that you didn't think you learned, or tips or things like that that you might want to share to next year's group that you didn't think were possible?
That's great. The question is, are there any tips that our interns would give to the next round of interns to help them on their way?
I was surprised by the amount of flexibility that I had in my contract. I hadn't been prepared for that, so definitely I would recommend that they reflect on what their priorities are, both their learning objectives and really content areas, and to be prepared for the flexibility that might come.
Does anyone else have a thought they'd like to share?
You should prepare to be flexible for the first few weeks of going through security. But, matching went really well, so go in knowing that you know how to communicate with your mentor, what you want to work on, and good expectations. I was able to do that with certain guidance, and that wonderful. So I reiterate it.
Sanjana, any tips for CDC interns? Anything you would add, Chris? Any other questions? All right. Well, I appreciate everybody coming today. I think this was really invigorating, at least for me, and I hope it was for you. We're so pleased that you all had such great internships, and I'd like to ask all the interns to stick around afterwards so we can get a picture. And there's still food left. Everyone help yourself. I think I had other announcements to make, but I think probably we're good, and we're out early. So thank you so much.
Interns. No, this group. Yeah, for sure.
We took